Hello and welcome. My name is Alvin Jeffrey. I'm a postdoctoral fellow in the Department of Biomedical Informatics at Vanderbilt University School of Medicine, and also funded by the U.S. Department of Veterans Affairs as a medical informatics postdoctoral fellow here in Nashville, Tennessee. Today I'm going to be talking about a prediction model I developed for disability and mortality among injured older adults. I'd like to acknowledge and thank my co-authors, Mary Dietrich and Kathy Maxwell, without whom this would not have been possible, as well as would like to acknowledge the use of the resources at the Department of Veterans Affairs. And as a disclaimer, my views are solely my own and don't represent those of the VA or the United States. So by way of a little bit of background, our previous work among injured older adults identified associations between physical frailty, cognitive decline, and the outcomes of those patients. Others have reported increased incidence of elderly patient injuries, along with a skilled nursing facility disposition in up to a third of patients, and a one-year mortality among as many as 25% of patients. So with these poor outcomes and the increased number of resources needed for these patients, we wondered whether we could identify the most high-risk patients to intervene early. So the objectives of our study were to develop a clinical risk prediction model for prognosticating disability and mortality among injured older adults 1 year after their hospitalization. And the idea or the rationale behind this was that if we could predict which patients are most likely to experience subsequent functional decline or mortality, we could enhance decision-making between patients, families, and clinicians. As a little bit more background before jumping into the methods, clinical prediction models are increasingly popular, and there wasn't an existing model to predict outcomes for injured older adults to our knowledge. So we used a secondary analysis of prospective longitudinal study with data collected between 2013 to 2014. This included 188 patients all over the age of 65 who were admitted to the emergency department with a primary injury diagnosis. And so what I'm outlining below are the outcomes or the variables that we collected at different parts of this prospective longitudinal study. So a patient would come in, they were injured, and we would ask surveys of either them or a proxy about their pre-injury baseline, things like physical function, cognition, and their living location. During hospitalization, we also collected some variables such as their age and gender, how they were injured, how severe the injury was, and which service admitted them. And then after hospitalization or after discharge, at 30 days, 90 days, 6 months, and a year, we re-evaluated or reassessed their physical function and cognition based on the same surveys we used as their pre-injury baseline. And so the idea of the prediction model is, could we take the data we had at the pre-injury baseline and their hospitalization to predict 1 year outcomes after that time of injury? The instruments that we had used in this prospective study to measure functional status included the Vulnerable Elder Survey, the Barthel Index, and the LifeSpace Assessment. So these give ideas of their self-reported or self-rated health, the physical tasks they perform, their activities of daily living, and even how far they move about from their primary living location. On the cognition side, we measured their AD8 for memory and thinking, and the IQ-CDE, which is used by surrogates to evaluate memory and intelligence. We also looked at comorbidities, their injury severity score and mechanism of injury, as I'd mentioned, their living location, and the admitting service. So to give you an idea of how these patients looked for their outcomes, I'm presenting the Barthel Index, and we chose the Barthel Index as the primary outcome measure because it's not only increasingly used in the clinical arena as a predictor of mortality, but it had nice variance or variation among the patients to allow us to predict an outcome to be able to put them in different categories and had that greatest dispersion of data. And so you can see the red color at the top is those that had a high Barthel Index, and you can see there are many pre-injury, and then it decreases very quickly at 30 days, but increases again, versus those with a low Barthel Index are in blue below, and then unfortunately a few patients did either die or pass away, and some that we didn't get data on to follow up. So as we thought about building this prediction model and knowing that we wanted to use the Barthel Index given its high variance, we also said, well, could we measure which patients are going to die or include that in the model to get an idea? So the part I'm really excited about is that we used a proportional odds regression model to treat the outcome as an ordinal outcome, with death being the lowest functional class. It may be a weird way to think about death, but in a proportional odds model or this ordinal model, you want the outcomes to be able to be moved through, or that each step is better than the last one. And so the assumption we made was that a low Barthel Index would be better functional status or preferred over death, and then a medium Barthel, and then the highest Barthel. And that allowed us to model both outcomes together, which as I mentioned, I'm excited about. So during the development and validation of the model, we emphasized overfitting as much as possible because it was a relatively small data set. So we used 15 cases per parameter as a minimum, leaving us with 11 degrees of freedom, and then applied penalized maximum likelihood estimation. We also needed to do some dimensionality reduction, so we used a Spearman's rho to assess multicollinearity, and then we applied a principal component analysis to collapse those theoretically less important predictors into fewer predictors. And then finally, as I mentioned, we used a proportional odds regression, applied restricted cubic splines to the predictor variables that we thought would have a nonlinear relationship with the outcome. And then finally, we did an internal validation with a 100,000 iteration bootstrap. So rather than creating a separate test set, we used all of our data and then anticipated performance and looked at optimism through a bootstrap. So the results of this model, for the full model, the adjusted R-squared was about 0.45, and for our approximated model, which I'll discuss here in a second, we got a 0.86 of the full model. The figure that you see in the bottom right is a relative importance of the various predictor variables, with those variables at the bottom being most important. So you can see the life space assessment was the most influential variable in predicting death, or the Barthel index. And even though the Barthel index you would think would be highly correlated, and it is a strong predictor. It falls kind of in the middle or at the bottom of the top 4 of predicting the actual outcome. And then the first principal component, or the cognition, the AD8, was not as predictive of functional status later on. To think about how accurate the model was, we used calibration in the large plots, which is a plot to say at different ranges of predicted probability to actual probability of a particular outcome, how does the model compare? So the x-axis is the predicted probability of the model, and the y-axis is the actual probability of, in this case, crossing the lowest intercept. So this would be surviving and reaching at least a low Barthel index. And so you can see that the gold line falls pretty close to the perfect diagonal line, which would have been perfect calibration or perfect accuracy across the range. As we move up to the other 2 intercepts, we also see that the gold line falls pretty close to the dotted line, and with some overprediction in some ranges and some underprediction in other ranges. And then finally, in the highest intercept to predict those reaching high Barthel, the same thing, pretty close. And so we were impressed and excited about the calibration performance of the model. So if we want to get to an aspect where we can interpret this or actually do something with it, one option is to create a nomogram. If you haven't seen a nomogram before, I'm going to show you an example on a slightly similar or a simpler nomogram on the next slide, but we can include all the variables in the model and have clinicians calculate for their particular patient that individual patient's probability of achieving low functional status, at least a medium or high functional status. So that can be a little overwhelming on the complex one. So let's start with the simpler nomogram. When I mentioned there was a simpler model that I created, even though we put all of the variables into a full complex model, we may not necessarily need all of them or have the time to calculate them all in clinical practice. So one option is to, instead of predicting the original outcome, predict the predicted probabilities of the complex model, and then drop out variables that weren't important in predicting the predicted probabilities. And so that's what we have here, is that variables that didn't have as much weight are removed to make it a little easier to calculate. So how would we actually calculate a patient's probability using this nomogram? We're going to take each of the variables on this fictitious patient who's 85 years old with a pre-injury Barthel index of 19, life space assessment of 100, an AD8 of 1, an injury severity score of 10, and a comorbidity index of -5. Again, this is just an example. And so for age, for example, we find the value of 85 on the line and then draw a line up to the number of points assigned to that particular value. So in this case, an age of 85 would correspond to 23 points. And we're going to end up adding these all up, so we want to keep track of them. The Barthel index, which was 19, would correspond to 73 points. A life space assessment would correspond to 78 points. An AD8 of 1 would correspond to 15. An injury severity would correspond to 40. And a comorbidity index would correspond here to 38 points. So we can add all these up, which would be 267. And then we can draw a line at the bottom where you see from total points to the predicted probabilities. So for example, the interpretation for this patient would be that they have at least a 95% chance of surviving and reaching at least a low functional status, about a 95% chance of achieving medium functional status, and more like 70% of achieving the highest functional status. You could also embed this into a computer program, whether it's an Excel worksheet or what I've presented here as an example from my website at quantitative-nurse.com, where you can actually input the patient's values and not only get their point estimates, but the confidence intervals around them. So in conclusion, we discovered a moderate statistical signal that could contribute to a useful clinical prediction model. And we found that information from the approximated models and the simpler nomograms could be used by clinicians, patients, or even families in shared decision-making related to likely health outcomes and subsequent resources and therapies. From a methodological standpoint, we demonstrated being able to combine mortality and another outcome in the same model. And so our next steps, this was a pretty small data set, so we need to move on to external validation and a larger sample size. And if it interests you, I'd be happy for you to reach out to me and talk about replicating the data at another site. You can find more details in our paper that was published in the Archives of Gerontology and Geriatrics that you see here, and it was published in January of 2018. I appreciate you taking the time to listen and expressing an interest in my work. Please feel free to reach out to me on Twitter or via my website or LinkedIn. I'd be happy to hear from you. Thank you.